So I am very pleased and delighted that today's webinar is going to focus on direct entry midwifery. And I am honored to introduce our two speakers. Dr. Courtney Everson is the Dean of Graduate Studies and Academic Faculty at the Midwives College in Utah, which is the largest accredited direct entry midwifery school in the U.S. She's also a medical anthropologist with research and teaching expertise in midwifery, doula care, perinatal health inequities, and interprofessional collaboration. Dr. Everson is also director of the research education for the Midwives Alliance of North America, the Division of Research, the vice president of the Association of Midwifery Educators, and serves on the board of directors of both the Midwifery Education Accreditation Council, and we are very pleased that she is a member of the Academic Collaborative for Integrative Health Board. As I read both their bios, and I've just got off a call with the National Academy of Medicine where we are talking about stress and burnout and resilience, I often think about how much time the people in our disciplines are putting into their areas of expertise and also in the larger collaborative healthcare movement. Then I am also very pleased to introduce Dr. Abigail Ayatola. Aipola. My goodness me. I'm a little bit on sleep deprivation here. And she's a naturopathic physician and a licensed midwife specializing in integrative gynecology, fertility, and preconception care. Dr. Abigail is the Associate Dean of the School of Naturopathic Medicine at Maryland University of Integrative Health and also serves as a board secretary for the Midwifery Education Accreditation Council, MIAC. She's co-chair of the Midwifery Clinical Training Task Force and sits on the steering committee and several task forces within the U.S. midwifery education, regulation, and association, which is, and Dr. Abigail is the incoming chair of the board of directors of the International Center for Traditional Childbearing. It's a midwifery organization that works to increase the number of midwives and doulas of color and to eliminate the effects of systematic racism on Black birth and breastfeeding outcomes. Her passion for the global empowerment of women and children is a common thread in all she does. So I'm very pleased to introduce both of our esteemed speakers today, and now I will pass over the mic.
Wonderful. Thank you very much, Liza, and welcome everyone to today's webinar. We are excited to be with you here this morning to discuss direct entry midwifery. Specifically, our focus today will be on providing you an overview of the issues, challenges, and opportunities in our field as it relates to race, access, and equity. My name is Dr. Courtney Everson, and I will be co-presenting today with my colleague, Dr. Abigail Ayapola. On a quick logistics note before we begin, we will be making our slides available to you following today's webinar as well as a recording. We also want to start off by recognizing that what we cover here today is just the tip of the iceberg when it comes to these issues. So our goal in our short hour together is to provide a foundation from which to launch further dialogue among the integrative health professions. So with that, just briefly, our purpose, of course, is to provide you that overview of current issues and challenges facing our field, specifically around equity and access. And to accomplish this purpose, we are going to be covering, first, some fast facts about the direct entry midwifery discipline. Second, we'll dive a little bit into perinatal health inequities facing childbearing families. Then we will look at some challenges around race, access, and equity that we're grappling with here in midwifery. And then we will be looking at some of the actions that are being done on systems level and in a collaborative way across what we call the allied midwifery organizations. We'll end today's webinar with some future directions and opportunities, as well as a brief question and answer period with each of you. So first up is Dr. Ayapola to discuss some fast facts about our discipline.
Dr. Courtney, I just want to make sure that you're showing your screen.
I am.
Okay.
It looks like I am.
Thank you.
Yes, of course.
Great. So this is Dr. Abigail, and as Courtney said, let's talk about some fast facts about the midwifery profession as a whole and direct entry midwifery in particular. So what is a midwife? Interesting question. It seems like it should be simple. Ironically enough, right now, the International Confederation of Midwives, the ICM, is having their council meeting in Toronto right now. And next week, the Congress will be meeting where midwives from all over the world will be joining together to talk about certain things that are particular to the profession. So the ICM, this organization that supports and represents professional midwifery associations around the world, defines the midwife as follows. The midwife is recognized as a responsible and accountable professional who works in partnership with women to give the necessary support, care, and advice during pregnancy, labor, and the postpartum period, to conduct births on the midwife's own responsibility, and to provide care for the newborn and the infant. This care includes preventative measures, the promotion of normal birth, the detection of complications in the mother and child, and the access, of medical care or other appropriate assistance, and the carrying out of emergency measures. The midwife has an important task in health counseling and education, not only for the woman, but also within the family and the community. This work should involve antenatal education and preparation for parenthood and may extend into women's health, sexual or reproductive health, and child care. That's the definition from the ICM. And so on this slide, we really want to focus particularly on direct entry midwives. And so why direct entry midwives when we have a definition for midwives as a whole? Well, in the United States, we have different routes to midwifery education, the profession of midwifery. And primarily, it is through nursing. And so what I will do in this slide is compare and contrast the CNM, the Certified Nurse Midwife, and the DEM, Direct Entry Midwives, or CPM, the Certified Professional Midwife. You'll learn a lot during this webinar. The CM, the Certified Midwife, the LM, the Licensed Midwife, you've got the Traditional Midwife, lots of different midwives. And so the ICM a few years ago went to the United States and said, just tell us the minimum standards for education, regulation, and association for midwives in the United States. And that is what brought together a lot of organizations, national organizations, midwifery organizations, to start having this conversation together. And that is what US MIRA is, the United States Midwifery Education, Regulation, and Association. The two primary certifying bodies are CPMs and CNMs within the United States. What's the difference? In a nutshell, the CPM, the Certified Professional Midwife, is the certifying credentialing body, or the certifying credential for direct entry midwives, whereas the CNM, Certified Nurse Midwives, is the certifying body of nurse midwives. Direct entry midwives primarily practice out of hospital, while nurse midwives primarily practice in the hospital. And out of hospital can be home birth or birth center. There are nurse midwives who practice within the birth center or help to assist deliveries at home as well, but primarily in the hospital. And then direct entry midwives are guided primarily by the midwives model of care, which I will define earlier. I want to share a few statistics with you, just so you understand the landscape of midwifery in the United States. So in 2012, and this is an excerpt that I'm actually reading from Keisha Good's dissertation on midwifery and the midwives' experience and mothers' experience in the United States. So in 2012, CNMs, nurse midwives, attended 7.9% of all U.S. births. Of that 7.9%, 94.8% of those births took place in the hospital. The remainder took place outside of the hospital, primarily in freestanding birth centers. That was 2.5%, and residencies, home, 2.5%. CNMs, nurse midwives, primarily attended the births of white women, 57%. 23% of those CNM attended births were to Hispanic women and 13% to Black women. Of those CNM, again, hospital, I will get to the DM, attended Black births, the vast majority, 98.7%, occurred in the hospital. In 2012, Eugene de Klerk analyzed the trends of midwife-attended births and found that CNMs attended a disproportionately high number of births to non-white mothers, whereas the births, well, let's just leave it there. So now the CPM, who is an independent midwifery practitioner, she has specialized knowledge and training of out-of-hospital births. And that's what differentiates the direct entry, or the CPM midwife, from the nurse midwives. She's primarily trained in normal physiologic births that occur out of hospital. Sorry. There's no authority. I'm going to get to some of these other regulating bodies. So the CDC doesn't really report data specific to the CPM. Instead, these midwives, CPMs, are given an other midwife category, which includes CPMs, CMs, DEMs, and traditional midwives. In 2012, so the same year of the statistics that I shared earlier, less than 1%, so 0.7% of all U.S. births were actually attended by this other midwife category. And the vast majority of those births took place outside of the hospital. And primarily, in this case, 70% were at home. We're going to talk about the organizations, the national organizations that represent CNMs and CPMs as we move forward. But moving to the next slide, the midwife's model of care is based on the fact that pregnancy, and this is the philosophy that guides midwifery, direct entry midwifery practice, is based on the fact that birth is a normal physiologic process and not something that automatically requires medical interventions. And to support this model of care in practice, the midwife's model of care accomplishes the following. One, similar to the definition, the ICM definition of midwifery, we monitor the physical, physiologic, and social well-being of the mother throughout the childbearing cycle. Also, providing the mother with individualized education, counseling, and prenatal care, continuous hands-on assistance during labor and delivery and postpartum support. Primarily, also, the midwife's model of care minimizes technological interventions, generally speaking, identifies and refers individuals to obstetrical attention where necessary, and the application of this midwife's model of care is client-centered and has been proven to reduce the incidence of birth injury, trauma, and cesarean section. Our next slide is a graph of the United States, and it gives a visual of where in the United States direct entry midwives are recognized, and that's the work of NACPM, the National Association of Certified Professional Midwives. And all of the states in green are where there is licensure, and that's 33 states. We just recently added Alabama to that to make that 33rd state. In contrast, certified nurse midwives are nationally recognized in all states, in all 50 states. The yellow states that you see in this graph are where direct entry midwifery is actually illegal to practice. So an important fact / challenge of the direct entry midwifery profession, in addition to our small numbers, is this licensure. We continue to fight for recognition, and that is, again, the focus of the NACPM, as well as all of our other organizations, but NACPM in particular. And this issue of equity and access, which is the focus of our talk today, shows up in a lot of different forms. And this legal piece, or this professional legislation piece, is a major part of it. Courtney?
Thank you, Abigail. So with that context in mind and introduction to our field, we want to start talking more about issues of access and equity by acknowledging the context that we are facing here in the United States, namely something that we call the perinatal healthcare crisis. So this crisis can be seen in a variety of metrics, as well as the narratives of families who are increasingly calling out the discriminatory treatment, the obstetric violence, and the poor health experiences manifesting in our current maternity care system. So for example, when we look at the quantitative side of things, the statistics, the U.S. ranks 33rd on the 2015 Mothers Index, which, as you may recall, is a global index evaluating the overall well-being of mothers and children by nation. In addition, we are 57th for infant mortality, meaning a baby born in the United States is less likely to see its first birthday than a baby born in Switzerland, Denmark, Estonia, Cuba, Belarus, and the list goes on. In fact, a leading report from Save the Children asserted that, quote, "Today, an American woman faces the same lifetime risk of maternal death as a woman in Iran or Romania. The United States is also among the countries making the smallest strides in saving children's lives." End quote. Tragically, the U.S. lags behind despite the fact that we spend more than any other nation per capita on maternity care. Additionally, deep inequities in these already poor outcomes are seen by race and ethnicity, along the lines of age and socioeconomic status, for gender identification, sexual orientation, and other marginalized social identities. Now, these inequities are most pronounced for communities of color. So here on the screen, I'm pulling up a chart that examines the final birth data for 2015 published by the National Center for Health Statistics. And this is the most recently available data released earlier this year. So you can see I've selected 4 key indicators of morbidity and perinatal health to highlight this crisis context that we are really facing for midwives. So first up, we see that our national cesarean rate in the U.S. is at 32%, which, as many of you may know, is far from optimal and nearly double what the World Health Organization recommends is a safe population level rate. Additionally, leading the pack with a 35.5% cesarean rate is non-Hispanic Black individuals, followed by Asian and Pacific Islanders at 33%. Whites, in contrast, are just below the national average, and this will hold true across the different key indicators of morbidity and health I'm highlighting here. When we move to low birth weight, we see that the national rate is 8.1%, again, suboptimal, and inequities continue to persist here as well, with non-Hispanic Black communities experiencing a staggering 13.3% low birth rate, followed by Asian and Pacific Islanders, American Indians and Alaska Natives, and Latina communities. For preterm delivery, the national rate is at 9.6%, as you can guess, also suboptimal, and yet within that, inequities continue to persist. Here again, seeing that non-Hispanic Blacks are experiencing a 13.4% prematurity rate, followed by American Indians and Alaskan Natives. So I want you to think about this for a moment. For low birth weight and prematurity alone, Black mothers in the United States experience these adverse outcomes at 1.5 to 2 times the rate of their white counterparts. And then when we go and look at mortality, for instance, infant mortality, we see that non-Hispanic Black communities are devastatingly experiencing the highest rate at 13.31 demises per 1,000 live births, followed by American Indians and Alaska Natives, and then Puerto Ricans. So right about now, you may be thinking, well, what about confounding factors? Couldn't other things be influencing the association between poor birth outcomes and racial and ethnic disparities? Could the increased rates be due to underlying genetic differences, maternal smoking, inadequate prenatal care? What about poverty? How about multiple obstetric risk factors combined? Well, here's the kicker. Even when researchers account for known risk factors and confounding factors, the inequities by race and ethnicity in the United States persist. Study after study has confirmed this, and even when taking into account all these other things, we can still only explain 10% of racial and ethnic inequities. This is where we must turn to a closer examination of what we call the social determinants of health, and specifically systemic racism, which Dr. Iopola will review for us here. Abigail?
Thanks, Courtney. So let's talk about determinants of health in general, and specifically social determinants of health. Determinants of health reach beyond the boundaries of traditional healthcare and public health sectors. So Healthy People 2020 defines social determinants of health as the range of personal, social, economic, and environmental factors that influence health status. This graphic here shows 5 different areas. We've got neighborhood and the built environment. We've got, in case you can't see it all that well, we've got health and healthcare. We've got social and community context. We have education, and then economic stability. Healthy People 2020 also has categories within social determinants of health, such as policy making. They overlap with these areas in this graphic here. Policy making, social factors, health services, individual behaviors, and biology and genetics. And I'll just take a moment to talk about the importance of understanding the interrelationships among these factors. And it is this interrelationship amongst all of these factors that determine an individual's and the population's health, not any one factor alone. So because of this, interventions that target multiple determinants of health are most likely to be most effective. So for instance, policies, one of the categories. To what extent do local, state, federal policies influence health? So example, taxation on cigarette smoking. That actually does something. Social, to what extent do resources, transportation, exposure to cell or mass media, social support, exposure to crime and violence impact an individual or population's health? Physical, the category of physical determinants. So natural environment as well as the built environment, lead exposure, the work, the school, the recreational setting, toxic exposures, individual behaviors. So what is this individual or population or communities? Spiritual connection, dietary habits, physical activity, emotional wellness, things like hand washing, etc. And then finally, you have biology and genetics. So this is where family health history, population, the statistics that we see in research, age, sex, inherited conditions. Now, health equity approaches are part and parcel of a larger social determinants of health framework. Social determinants of health factors such as where we live, our access to, and the quality of the health care that we receive, our economic and educational status, and our larger social and community context, as illustrated in this figure. Next slide. This is a graphic here that was put together it was jointly produced by ICANN, ICTC, MANA, Elephant Circle in 2015. Courtney, do you mind, can you advance it? Perfect. And so we talked about social determinants of health, and now let's talk specifically about how systemic racism, how the social determinants of health all relate specifically to perinatal health inequities. And stress is a big one. So if you can imagine for a moment, now that we've identified these various components that factor into determining one's health status, whether individual or population, imagine the compound effect of having multiple things from multiple of those categories on your mind at any given moment. And what does that do to that person's health or that population's health? So this infographic here talks about that. And the word that's used in research and in studies around is allostasis or allostatic load. And allostasis or allostatic load is the process by which the body responds to stressors in order to regain homeostasis. This is an adaptation, a physiologic adaptation to stress and how we mitigate or not disease. So how does this impact pregnancy and perinatal outcomes? So the HPA, the hypothalamic pituitary axis, this is where dysregulation can occur when there's a lot of stress. We have increased cortisol, we'll get increased inflammatory responses, increased vasoconstriction, so less blood flow to the baby or the placenta and such. And so things, for instance, those outcomes that Courtney, Dr. Courtney, I should say, outlined in previous slides, like low birth weight babies or preterm labor, those actually have a direct correlation to stress, which has a direct correlation to these social determinants that factor into one's health. And so another statistic or other numbers that you can look in this in the bottom corner of the slide here is that researchers found that African American women in particular who are pregnant in comparison to white women who are pregnant are 4 times more likely to die from pregnancy-related complications, 2 times more likely to experience preterm birth, 3 times more likely to give birth to a low birth weight baby. And these are the bottom numbers. In some communities, these numbers are as high as 10 or 13 times the rate of what white women would experience in the same situation. And remember, again, this is controlled for all factors, those confounding factors, again, that we mentioned before. So while these pathways of stress are really the most well documented in communities of color, similar mechanisms are at play for other marginalized communities and identities of people along lines of age, gender, sexual orientation, just to name a few. Moreover, structural barriers can further confound this cycle of stress and poor birth outcomes, including access to care, food insecurity, urban pollution, unstable housing, to name a few. One of the solutions proposed here in this infographic was to match, and this is what's circled in red here, was to culturally match pregnant mothers or individuals with doulas and midwives because of that midwives model of care, that individualized process, and support for physiologic birth. Dr. Courtney.
Thanks, Dr. Abigail. So yes, so you can see at this point in this webinar what we're up against as we look at the perinatal healthcare crisis and landscape here in the U.S. So if culturally matched doulas and midwives are proposed as a potential solution, and if we think of the well-documented benefits of midwife-led care in physiologic birth, then we must critically ask the question, who gets served? So as Dr. Abigail alluded to earlier, out-of-hospital births make up a total of about 1.5% of all births in the U.S. And in about a decade's time, this did rise approximately 72%. So this is great news for midwifery, specifically direct-entry midwifery, as direct-entry midwives are primarily the ones attending these out-of-hospital or community-based deliveries. But if we dig a little deeper, then what we realize is that the rise in midwifery care is being disproportionately driven by non-Hispanic white individuals. And communities of color are once again not benefiting from this care model to the extent of their white counterparts. And so we can tout midwifery care as a potential solution all day and all night, but until we ask care for whom and ensure access and equity issues are deeply addressed, we will always fall short of anything transformative. So this realization leads us into a brief review of the main challenges facing midwifery before we turn to some of the opportunities in the work of the allied midwifery organizations. Abigail, for the challenges.
And there are plenty. So I just want to remind you, as we mentioned at the beginning of our talk, this is just the tip of the iceberg in terms of this discussion and what are the challenges and what are we doing. Another thing that I want to mention is that one of our goals for this webinar is, in addition to sharing some insight into the direct entry midwifery profession and how we particularly are addressing these issues, is to spark thoughts in your mind about how you might approach these issues within your profession as well. And of course, how you can support us in our work as well. And how can we work together interprofessionally, collaborating and working on systems change around access and equity and race and such. So yes, there are multiple challenges around race, equity, access in general. We've shared a little bit already about how some of these challenges show up in perinatal health. And you should know, be warned, that if you're going to grapple with these issues of equity and diversity within your profession, you will come up against these and other challenges. So systemic oppression in the midwifery profession. So ironically enough, though it hasn't been the history, the onset of midwifery, globally and certainly in the United States, the profession of direct entry midwifery seems to have transformed into one of privilege, even though it doesn't quite seem like that because we are a small number of providers, midwifery included, within the United States, as I shared earlier. But it does seem to have turned into a profession that only few can access, despite the fact that those who would benefit most from our work do not look like those who primarily operate and are members of this profession. So that's a challenge. Privilege. Microaggressions exist. Underrepresentation is real. There are national, very few national, and lots more grassroots organizations that specifically deal with issues of equity firsthand and quite regularly experience these microaggressions and challenge this underrepresentation. We'll talk about the AMOs in a few slides to come. Access to care. So we have barriers in terms of access to care. This is real. Think back to our discussions about the social determinants of health. So you can't actually blame it all on the women, the people, the communities themselves. And these barriers in terms of access overlaps with the representation in the profession and all professions that deal with birth. And then chasms in interprofessional, so what's going on with midwives and OBs? What about perinatologists? What about NDs, naturopathic physicians, and MDs or family doctors? What about the community health workers? And how is all of this confounded by legal parameters? Social determinants of health. Well, enough said about that. Besides the fact that this is a lifetime of exposure, we must look at midwifery care in a wider context, not just what we're doing in the office or in the home setting or in the birth center setting. What else is this person, this family dealing with that might be impacting their pregnancy and their birth? Now, let's be real. Not everyone agrees. Not everyone agrees about how to prioritize. Not everyone agrees about how to approach. Not everyone even agrees that this is a concern or that this is even a thing. Students, apprentices, midwives, there are a lot of challenges in that regard. And just related to that, there are competing priorities, whether perceived or real, and both exist. Well, how can we tackle this X, Y, and Z, equity, access, inclusivity, etc., when we have other pressing things like these babies who are dying? Well, my comeback to that is when you support a Black woman who has, again, back to the stats that we've shared with you that already and earlier, when you support a Black woman in birth, you actually are improving outcomes for everyone. So we're going to just transition here into the AMOs. And the AMOs are the Allied Midwifery Organizations, and the actions that these various national organizations are taking to make change, specifically in terms of access and equity. So the AMO, the AMOs, Allied Midwifery Organizations, is a coalition of midwifery organizations working together to advance the profession of midwifery, direct entry midwifery in particular, and address pressing issues like equity and access. So as we highlight these organizations, we're going to talk specifically about how each organization is working to address equity and access within midwifery. So we've thrown around a lot of acronyms here. I talked about USMIRA, the United States Midwifery Education, Regulation, and Association. And then AMOs now, this Allied Midwifery Organization. What's the difference? AMOs, in particular, the AMOs are specifically the organizations that represent direct entry midwifery. And we're going to Dr. Courtney and I are going to tag team these organizations and speak about how they contribute to the midwifery profession. But I'll just highlight them right now. So MANA, Midwives Alliance of North America. This is the umbrella professional organization. And we have a few professional organizations back to the midwifery soup and the different, paths to midwifery. But MANA has been around and has taken on the identity of having this umbrella organization. Then you have the NACPM, the National Association for Certified Professional Midwives. Not all direct entry midwives actually have the CPM certification. So in an attempt to be recognized by all states and standardize and streamline and have a unified message, NACPM is working to bring all direct entry midwives and understand this profession, this certification will help us get more recognition, or at least unify our language so that when we go to Capitol Hill, when we try to change legislation, people understand what we're saying. NARM, the North American Registry of Midwives. This is the certifying body. This is the organization that writes the exam for the CPM. MEAC, the Midwifery Education and Accreditation Council. Both Courtney and I are on the board of this organization. This is the accrediting agency for the direct entry midwife. More information on all of this to come. AIM, the Association of Midwifery Educators. This is the professional organization of midwifery educators, something like the Council of Colleges and other professions. And then ICTC, last but not least. This is the International Center for Traditional Childbearing. This is the organization, the national organization that represents midwives of color, midwives and doulas of color, because again, midwives of color are drastically underrepresented in all of these organizations. And so we are working to get pipelines into midwifery, and this is where doulas and other birth providers are. So then where does USMERA fit in? Well, USMERA this is where in response to the ICM saying to the United States, hey, get your act together and just tell us what are your minimum standards for midwifery education, regulation, and association for the nation. Well, then that talks about CNMs and CPMs, nurse midwives and direct entry midwives. So we started talking, all of these organizations. And so 2 additional organizations would be represented within USMERA, and they are well, 3 really. ACNM, that's the American College of Nurse Midwives. That's the professional association of the profession. ACME, that's the accrediting body, and AMCB, and that's the certifying, that's the body that creates the licensing for that organization. So to start and to dive into each of these organizations, we'll start with NACPM. So as I mentioned already, the National Association for Certified Professional Midwives, the way that they have been grappling with issues of access and equity is specifically about the profession. How do we, so they have a strategic and outward commitment to this work. How do we get recognized nationally? And how do we address racism and racial disparities within the United States maternity care? They also work together to have thoughtful, expanded representation and shared leadership structure. So recently they changed their board structure to have a cross-racial and co-presidency, and so that NACPM could intentionally and strategically raise more leaders of color within the profession of midwifery. NACPM focuses on systems level change, both within the organization itself and on national level, so making policy. So they have a board team, the AROM, the Anti-Racism and Anti-Oppression in Midwifery, where they tackle these things. NACPM works to provide webinars on professional development for all midwives that focus specifically, they have series on different things, but they have a particular series that focuses on equity, race, and access. And they're all housed on their website. You can download and listen to them right now. And NACPM finally, in addition to other things, but finally for this slide, has, they recognized a community of color-led initiatives to eliminate inequities. So for instance, they have a Grand Challenge Scholarship Fund to help support more future midwives of color getting access into the profession.
Thanks, Abigail. So in addition to NACPM, we also have MANA, the Midwives Alliance of North America, who are working on many things, including access and equity. And what we're trying to do in these slides here is help to highlight for you what our different organizations are doing in order for you to get ideas for your different respective disciplines. So for instance, in MANA, this organization works in terms of education and practice integration by outlining several core competencies. They outline core competencies for our field, but several of them include a focus, an explicit focus, on social determinants of health and on culturally appropriate care. We also, starting in 2014, integrated gender-inclusive language into our competencies, as not everyone that gives birth identifies as a woman, and representative language matters for access and equity in any given field. Now, on the professional development level, the annual meeting of MANA includes requirements for each and every abstract submitted that the presenters address and integrate into their presentations issues of critical cultural competence. And a large focus of programming at large that the program committee actually does is around ensuring that equity and access is infused into the entire conference and really highlighted. And so one of the traps people fall into when they're early on in this work is doing access and equity as kind of an add-on and stir. It's not the foundation and it's not the focus. And so programming matters, and it needs to be thought about at the very start of anything that you're hosting in terms of annual meetings or conferences. Finally, MANA, like NACPM, is working on a systems level change through their established MANA Division of Access and Equity, who is purely focused on these particular issues and leads a wide variety of initiatives, both within midwifery and in working on programmatic and policy realms, as well as through things like our MANA Division of Research, in which we help guide research and applied impacts related to health inequities and access issues. I also now want to turn to another of the AMOs, MEEC, that as Dr. Abigail denoted, we both serve on this board. And so MEEC is, as you recall, our accrediting body. And as the accrediting body, MEEC helps drive the bus on ensuring access and equity gets infused in not only the learning competencies for the field, but the actual structure of our midwifery schools and programs. So for instance, through our written standards for accreditation, we have specific benchmarks focused on accredited schools and programs demonstrating how their processes for recruitment in admissions, for instance, support equity and diversity. Or another example might be found in how these accredited schools and programs must create and demonstrate non-discrimination policies for both employees and students. There are, of course, several core competencies related to the social determinants of health and culturally appropriate care within the community setting of maternal and newborn health. So I also expect that many of you on today's call may be educators or administrators themselves. So I wanted to take just a few brief minutes to give you some resources for how some of our midwifery schools have been structuring and grappling with access and equity in higher education specifically. So the two that I want to highlight here today are the Department of Midwifery at Bastyr University, who have done an amazing job documenting their extensive work in the development of anti-racism and cultural competency courses in their curriculum through both a published article and a webinar on the topic. And I will give you the links for both of those in a moment. And then in addition to classes, individual classes, we have to think about equity and access on the larger issue of how do you structure your school or your program. So at my institution, Midwives College of Utah, we not only have courses in equity and anti-oppression and culturally safe care, but we take something called an ecosystemic approach. And so here on the screen, you can see a visual of our ecosystemic approach, which touches everything from curriculum to professional development for our faculty, to scholarship funds for aspiring midwives of color to diversify our workforce, to tailored support services, and so on. And on this slide, you'll also find the links not only to a larger document about our ecosystemic approach, but on the article and webinar I mentioned from Bastyr University. Now, a third or fourth, I think we're on now, of the AMOs is, as we mentioned, the Association for Midwifery Educators. So this is the last one I will cover here today before I turn it back over to Dr. Abigail. Our focus at AIM is on supporting midwifery educators, and this means both your academic faculty as well as your clinical faculty. So, for instance, we deliver a professional development learning system online called Digital Chalk, where we have courses available at all times to both academic and field faculty in things like best practices for ethics and social justice in midwifery education, inclusion and cultural awareness, and we also host all the archived webinars so that our profession and professionals can achieve CEUs, the webinars that are done by NACPM, as you learned about earlier from Dr. Abigail. So we're also in the process right now of really re-envisioning our approach to collaborations and what it means to ensure inclusion and equity in those opportunities and to advance these strategic partnerships, not only within our discipline, but across the integrative health disciplines and others as we prioritize the voices and needs of communities of color on the ground. And then, of course, we're always providing ongoing resources on these topics. This is not a one-and-done learning potential or area. This is an ongoing area that our educators must be grappling with. So for our final two AMOs, before we turn to some concluding remarks, we'll go back to Dr. Abigail.
Great, thank you, Courtney. So NARM, as I mentioned, this is the organization that writes the certifying exam. Well, it's just an exam. How do we incorporate and weave in issues of equity and access into an exam? Well, this is really important because students want to pass the exam. The exam is the foundation for the profession that as well. So NARM has based their exam competencies on MANA, and that's the association, MANA's competencies for the entry-level midwife. And there are specific foci on social determinants of health, non-discrimination, and culturally appropriate care, and others. NARM has also required competencies for current practitioners, and that's part of recertification. So how do you bring in cultural awareness into part of the recertification process? Again, keeping in mind, this is what we're doing within midwifery. How can we improve on this, and how can this also apply to individual other professions and disciplines? Both MEEC and NARM, so the accrediting body and the certifying body, collaborate. We talk. Well, what do you require your schools to do, and how, meaning what do you require the schools to teach? To teach within their program before students graduate, and how does that match with what we're requiring those students to learn or demonstrate competency when they take the exam to enter into the profession? And we're ensuring that this collaboration and equity are also part of MEEC's entry-level applicants. NARM also, back to increasing and diversifying the profession as a whole, has a bridge certificate, and this is specifically for increasing the recognition and interprofessionalism of already practicing midwives, and maybe midwives, direct entry midwives, who never in their particular state had licensure, and it wasn't required at that point. How do they get bridged into, back to what the ICM is proposing, and how do we work together to enhance the profession as a whole? And then finally, but certainly not least, ICTC, the International Center for Traditional Childbearing. And we left this for last because ICTC has been doing this work in terms of equity and access in midwifery for the longest time, and on a national level. There are lots of organizations that have been, as we've already shared, many organizations have been taking on pieces of this, even if their primary focus might be certification or accreditation. And that's all very important. But where's the organization? Where's the role for the organization that has the primary initiative for taking this on? And that's where ICTC comes into play. The vision and mission of ICTC is birth equity for all. Equity for all marginalized communities, all birthing individuals. And the mission is to eliminate specifically the effects of systemic racism on birth and breastfeeding outcomes. Again, this is the only national organization that brings together midwives of color regardless of their professional affiliation. So similar to MANA, that is the umbrella organization for midwives in general, primarily direct entry midwives. ICTC focuses on midwives of color, birth workers of color to be even more specific, or more general, really, birth workers of color, regardless of their professional affiliation. So MDs, OB-GYNs, perinatologists, doulas, lactation consultants, because we understand that it takes a village and that working together to address those social determinants and what is happening to the midwife of color within her profession, as we addressed earlier about microaggressions and underrepresentation. So the outcome for the community, the consumer, the birthing family, but then also for the individual professional who is also in her attempts to, or in their attempts to do their work, also experiencing effects of systemic racism. ICTC has done some impactful work, and I'll give an example in Oregon, insurance reimbursement for doulas. We talked about that infographic and how culturally matched doula support can actually, we have evidence to show that it improves outcomes. Well, how do we get insurance reimbursement for that so that, again, increase access to doulas for those communities who need it the most, who will benefit from it the most? ICTC has been the newest member of US MIRA. That was a challenge and a long haul to make that happen. And this highlights the critical need for diversification in the midwifery profession as a whole, workforce. And there are a number of other organizations, grants and funding, which we'll talk about in terms of future and outcomes and opportunities that we have for moving this work forward. So with that, we'll move to the last slide, which is really future directions and opportunities for the profession. So Dr. Courtney has already talked about MEEC, and here are some things that are already happening as well as opportunities and ideas, and this will take us straight into our Q&A. So if you have questions, you can go ahead and type them into the chat box now. So MEEC, the accrediting body, we every few years, 3 to 5 years, we do an entire revision of our standards, and the standards are what the accrediting agency requires of individual schools. We can't tell you how to do it, but we can say that these are the standards that are required that need to come out in your school. So best practices in education, increasing the standards of what our midwifery schools are required to do for maintaining their accreditation status. And within this standards revision, which is happening this year, it's about a 1.5 year long process, we're really doing a complete overhaul on the section that has to do with equity and cultural awareness. Dr. Courtney?
Yes, and I just also, before I go on in this slide, just want to do a quick time check. We only have about 8 or so minutes left together, and so we're going to try to cover this slide in 2 minutes to leave about 5 minutes or so for questions. So with that, I will say another one of our projects is on the coalition that is being formed right now on focusing on equity in midwifery education, not from an accrediting body perspective, but from an on-the-ground student, practitioner, and educator perspective, and really gearing up those resources, because we cannot expect something of our students that we ourselves do not fully grapple with and understand what that looks like in our profession. I'm going to cover just a couple more before I turn it back over to Dr. Abigail for the purposes of time. And that includes items such as NACPM gearing up for their CPM 2018 symposium. You know, every one of us in our fields have an opportunity to come together at several points throughout the year. Take this as an opportunity to focus your programming and structure it around race, access, and equity issues. When we look at external opportunities available to each of our fields, for us, that's the fact that more and more people are perking up and saying, wow, we have a serious perinatal healthcare crisis. What can we do? And so midwives, specifically direct entry midwives, are being looked at increasingly more in this regards, and that gives us a real opportunity to rise and meet the challenge. And finally, of course, we're going to continue as the AMOs to partner with grassroots organizations, specifically those that are being led by communities of color, to advance outreach work and needed change for families on the ground. I'll let Dr. Abigail highlight a few more opportunities, and then we'll go into your Q&A.
Yes, and I'm glad you said opportunities. Is a dream of mine. Imagine if we could have midwifery programs in community colleges, increase the pipeline and access to midwifery profession, and so more midwives on the ground to support midwives, mothers and birthing families. And then not only just community college, but other known pipelines. So where do doulas come into play? Where do community health workers, lactation consultants, nurses? What about our historically Black colleges and universities? What about pre-professional programs and having mentorship and support for incoming midwives before they actually enter into the program? Paying attention to, again, those microaggressions and the experience that particular student, midwifery student, will experience that will be different from other students. The Home Birth Summit, this is, I think there have been 2 convenings. This was a multidisciplinary group of stakeholders that represented varied perspectives to address shared responsibility for the care of those who choose home births. So physicians, OB-GYNs, NDs, perinatologists, etc., midwives, hospital administrators, researchers, insurance payers, liability specialists, etc., all came together to discuss home birth because, again, patient-centered, patient-led initiatives. So for those who choose home births, how do we come up with best practices and support their desire? What about funding for larger collaborative projects? We have some midwifery-focused funders who are really passionate about doing these. And I just learned about one that I think would be really interesting. I'd like to share here that I found out at the ACNM annual meeting that happened a couple of weeks ago. The Josiah Macy Foundation. They tend to fund IPE efforts, so interprofessional educational efforts. So there are 4 different sites where graduate midwifery students work side by side with OB residents and family practice residents and medical interns and a nurse practitioner and a farm student, and they share cases. These are hospital-based, generally speaking, also some birth center, but they work together. I've already shared a bit about US MIRA. And the work that's been happening together with these different organizations and the task forces, the steering committees, the working groups, the conversations with ACOG as well, talking about direct assessment, talking about competency-based education, thinking about our clinical training, thinking about equity. These are concrete task forces that have come out of US MIRA. And so with a couple minutes to spare, let's see if we have any questions. Thank you.
This is Liza, and before we move into that, I would just like to take an opportunity to thanks so much, Doctors Iapola and Everson. In many ways, as I'm listening to you both, the direct entry midwifery discipline is really a model, I would say, for all of the collaborative disciplines in looking at and hearing about how you've been focusing on access, equity, and diversity, because I think many of us have faced issues around turf elements with licensure, issues around reimbursement, and I was actually thinking that the 2 of you might be really excellent to oversee a project that our organization might begin to focus on, in particular these issues around access, equity, and diversity for all of our disciplines. And with that, I will pass it over to Renee, who I think is receiving the questions. This has been an excellent presentation. Thank you so much.
Thank you. And Drs. Abigail and Courtney, if you need a few extra minutes to answer questions, it's not a problem. So here's your first question. Can you explain some details about the bridge certificate? What is required?
Sure. Abigail, would you like to take it or would you like me to?
Go ahead, Courtney.
Great. So I'm going to bring up my notes about this specifically, but the bridge certificate, as Abigail alluded to, is really intended to help ensure a bridge between current practitioners and increasing requirements throughout the United States for all kinds of midwives via the U.S. Mare Association that we have emphasized here today. So in particular, some specifics I can give you in brief include the fact that there are 3 broad categories by which midwives are expected to engage in continuing education credits, and there's a minimum number in each category that's specified by the North American Registry of Midwives. And these categories include Category 1 is emergency skills in pregnancy, birth, and the immediate postpartum. Category 2 is emergency skills for newborn care, because remember, as midwives, we're always dealing with the maternal-fetal dyad, so at any given time, a practitioner needs to be ready to grapple with both. And then Category 3 is specific topics relevant to midwifery care, and it's concurrently like the catch-all category at the same time as it is a very focused catch-all category and deliberate, because it is focused on pressing issues in the field. So things like culturally appropriate and safe care, things like increased best practices in charting, especially with the advent of electronic health records, areas such as evidence-informed practice and interprofessional collaboration. Those pieces are all under that Category 3. So all categories together are intended to ensure all current practitioners, as well of course our new graduates going through our educational routes, have the opportunity to rise up and meet the challenge that we are facing here in the U.S. with not only the perinatal health crisis that we've went over, but the increased focus on U.S. MERA and coming together throughout our different professions. And, as Liza kind of mentioned, sometimes the turf wars, to say it was never about us, it was always about the families we serve. And this bridge certificate helps us to accomplish that goal.
Right.
Thank you.
And I don't know if the person asking the question wanted to know specifically about credits, but 50 continuing education credits are required, and they're really specifically outlined in terms of certain things from categories 1 and 2 in particular, because that's about the mom and about the baby, and then a certain number specifically from category 3, this catch-all bucket.
Thank you. The next question is, do you have a requirement for teachers in your schools to be trained as educators as well as content experts?
Yeah, that's an excellent question. And in MEAC, our accrediting body, we do have several standards that address this, that you are required to demonstrate as part of accredited programs or schools seeking accreditation, I should say, and then of course if you're accredited. And those include categories like being able to demonstrate that all of your faculty are, in our case, either midwives, because they're teaching midwifery, or that they have additional expertise in credentialing to teach the classes that they are teaching or overseeing, the areas that they are overseeing. In addition to the kind of content or discipline-specific nature of qualifications, we also have the pedagogical aspect that you are referring to, which includes things like adult learning theory. And so we have standards that specifically address the importance of ensuring that the educators have qualifications in and have ongoing training in adult learning and teaching theory, or requiring additional professional developments in things like race, access, and equity. And so we are striving to kind of hit the balance of content expertise with being trained in proper pedagogy, as well as ensuring that faculty are equipped with this ever-changing field that we are grappling with. So we do have very variable standards around that. In addition, as Abigail had mentioned on our last slide, we are in the middle of a standards revision, which gives us an excellent opportunity to further ensure that that is adequate for our field as we look at the changing landscape.
Maybe time for one more question?
Yep. Our next question is, what is the best way to support and to get involved in midwifery research?
Dr. Courtney?
That is a great question. So as you may recall, I'm the Director of Research Education for the Midwives Alliance of North America. And one piece we didn't mention in this regards is our Division of Research oversees the largest perinatal data registry on midwife-led care in the home birth setting in the United States. And so if you are interested in studying anything related to outcomes of care for midwifery care and community birth, I strongly encourage you to get in contact with me, and I'm happy to tell you about our research application process to access that very large data set. In addition, one of the positions I actually hold is exactly this. If you are a researcher out there that is interested in collaborating with other researchers already in the field, or even helping maybe aspiring researchers or student researchers in collaborative projects between, let's say, the different integrative health disciplines, I would be happy to actually administer a program called Connect Me that helps look exactly at that, and I would be happy to talk with you more about that. A lot of the opportunities just depend on your own positionality. Are you a researcher? Are you a practitioner? Are you a student? But regardless, I think personally that research is an amazing common ground and opportunity for us to work more across the divide between the different health professions, and again, ultimately focus on making change on the ground for the individuals and families that all of us serve. So please do get in contact with me, and my email is here on the screen.
So I once again just want to thank everyone for being on this call. Excellent presentation. I know that we look forward to putting it up on our website. And as all of you know, the collaborative really focuses very much on interprofessional education and collaborative practice. And I am really delighted that the direct entry midwifery discipline and your presentation focused on this most important subject that really all of our disciplines need to grapple with. So thank you again so much for being on the call, and we look forward to talking to you very soon as well.
Thank you all. We appreciate you.
Everyone have a wonderful rest of your day.
And I love it that you call each other by your first name, Dr.